among these all the drugs. And in this, some of the drugs used as a bolus doses, and some of the drugs as infusions, and some of the drugs can be used as a both. Now coming to the first drug, and objective C is mainly for the doses and also the indications. And aim to discuss only the relevant pharmacology. I am not switching on to other topics related to the cardiac arrest and pre and peri-arrest arrhythmias. And first and foremost drug is epinephrine or adrenaline. This is the one of the basic drug for the cardiac arrest scenarios. This is the inotrope and vasopressor. This is the first line drug for any pulseless electrical activity, any cardiac arrest, and if there is no pulse, the first drug to be used. It stimulates the adrenergic receptors. It acts on the both alpha and beta receptors. Let's say it is alpha and beta agonist. It has two actions. One is the inotrope and second one is the chronotrope. So it can increase the contractility as well as it can increase the heart rate of the heart. So mainly it increases the systemic vascular resistance. That's why it contract the peripheral vasculature by means of alpha receptors, and also it can increase the blood pressure. It can increase the myocardial oxygen requirements and also increase the automaticity. So whenever the patient is cardiac arrest, there's almost lack of rhythm, lack of automaticity in the heart. It can stimulate the sinus node and stimulate the heart to generate its automaticity. And it mobilizes the blood from the peripheral to the center so that it can increase the coronary and cerebral blood flow, which further help for the recovery from the cardiac arrest and also increase the cerebral blood flow to preventing the neurological damage. So mainly indications, as I earlier tell, cardiac arrest, VF, ventricular fibrillation, and pulseless VT, and asystole, and pulseless electrical activity. In the symptomatic bradycardia, it is not the first line. In the symptomatic bradycardia, always give first dose is atropine. Only atropine you can use up to maximum of 3 milligrams. If there is no response, then only you have to switch out to the epinephrine. And in case of severe hypotension, it's not responding to the vasopressors. You tried other vasopressors. If it's not responding, you can use the epinephrine, but not as a bolus dose in a severe hypotension. Maybe you can use as an infusions. In case of anaphylaxis, severe allergic reactions, along with the fluid resuscitation, you can use. In case of anaphylaxis, how can you use? You can dilute the drug. Would like 1 ml, you can make it up to 10 ml, so that you can get the 1 in 10,000. You can give the subcutaneous injections also, or you can use the bolus incremental dose of 1 ml, 1 ml. Because in this anaphylaxis reaction, maybe you have peripheral shock, but maybe cardiac activity is still there. If you give directly, there may be a chance of going into the arrhythmias and ETs. And also for the, and along with the fluid resuscitation, simultaneously you can do this epinephrine. And also simultaneously we can use corticosteroids and also antihistamines. What is the dose? Generally, it is available as a 1 ml ampoule. 1 ml contains 1 milligram. It can be as 1 in 1000. Actually, in ampoule, you can written as a 1 mg, 1 in 1000. That means here it is written 1 in 10,000 means you can see any cardiac arrest scenario, always dilute the drug to the 10 ml NS only. Because there is a circulatory shock to the total collapse. If you give 1 ml, that is in the peripheral vasculature only, it is not reaching the heart. That's why it is written 1 in 10,000. Ideally, it is 1 in 1,000 only. So you have to make to 10 ml again. It's becoming 1 in 10,000. So you have to repeat the adrenaline every 3 minutes. There is no described what is the maximum dose until you will get the ROSC of rate of spontaneous circulation. You can repeat the drug every 33 minutes. You can every 3 to 5 minutes. You can able to administer the drug. The basic dictum in a cardiac arrest scenario, giving any drugs, always give 20 ml saline flush. So you can't inject directly as a single drug like a 1 ml. You have to dilute the drug with 10 ml, and also followed by the rapid flush of saline 20 ml and raise the limb for 10 to 20 seconds. It is applicable for all the drugs, not only epinephrine. It can be applicable to all the drugs in cardiac arrest scenarios. Not in other scenarios. Particularly if the patient is cardiac arrest, there is no circulatory, peripheral circulation. In this situation, you have to rise the flush with the 20 ml saline. After restoration of spontaneous circulation, you have to start the infusions. So when the patient got the spontaneous circulation, that means you can able to feel the cardiac pulse. When the patient have spontaneous breathing efforts, you can able to feel the pulse. In these situations, you are not supposed to give adrenaline as a bolus dose. It will precipitate arrhythmias. So once you got the rhythm, when they got the spontaneous circulation, you can start the infusions at the rate of 0.05 to 2 micrograms per kg per minute. Endotracheal dose, generally it is not advisable. Suppose if in the patient in a severe shock, collapse state, you can't get any veins, you may try the endotracheal dose, that is 2 to 2.5 mg. That means you can use the 2 to 3 ampoules, 2 and 2.5 ampoules, and dilute in a 10 ml NS. You can rapidly inject into the endotracheal tube and followed by the doing ambu, so that it can reach the capillaries. So that once you give flush and always give ambu for 2 to 3 puffs, so that it can absorb into the systemic circulation. This is about the epinephrine or adrenaline. Coming to the norepinephrine or noradrenaline. This is a vasopressor. This is also vasopressor. It is noradrenaline is a naturally occurring catecholamines. Both are catecholamines. This is the naturally occurring catecholamines. It stimulates alpha and beta 1 receptors. When you compare the adrenaline and noradrenaline, basic difference is noradrenaline has more alpha actions than beta 1, whereas adrenaline has both alpha and beta, and all the receptors of adrenergic receptors, adrenaline will lack. Whereas norepinephrine has more of alpha and beta 1 receptors only in the sympathetic nervous system. It causes peripheral vasoconstriction. That is the basic advantage of noradrenaline. Is because of the alpha actions are more compared to the adrenaline, it causes the peripheral, renal, splanchnic, and pulmonary vasoconstriction. So whenever the patient has severe septic shock, he came to the casualty with the unresponsive state. When you are not feeling the peripheral pulses, this is the best drug. In the septic shock and the patient is severe anaphylactic reactions, where you can increase the peripheral vasculature, you can increase the systemic vascular resistance. In that situation, you can use the noradrenaline. We remember that noradrenaline is not a drug for bolus dose. It is the drug for infusions only. You are not supposed to give as a single dose like adrenaline. It should be given as an infusions only. The beta 1 stimulation increases the myocardial contractility with less tachycardia compared to the adrenaline. So it has both alpha and beta, and compared to the beta 1, compared to the tachycardia, when you compare the adrenaline to norepinephrine, it is less. At the same time, peripheral vasoconstriction is more compared to the adrenaline. That is the best drug for when you have systemic collapse, circulatory shock. And the dosage is 0.05 to 0.03 micrograms per kg per minute as an infusions. You have to titrate to the low to high dose as per the requirement, depending on the scenarios. Like whether you can able to, if you are not getting the adequate pulse or adequate BP, you can increase the dose of the noradrenaline. And coming to the indications, as earlier told, septic shock, severe anaphylaxis, when the labile BP, the unresponsive to adrenaline, and hypotension, unresponsive to the fluid resuscitation. If the hypotension is there, the patient is having severe hypotension. Suppose you are the hypotension, you always first fluids. So fluid resuscitation is always mandatory. Then you have to stop the noradrenaline. If you are not doing the fluid resuscitation, you are giving the noradrenaline. What is happening is you can have distal gangrene or ischemia of the distal peripheral circulation and skin ischemia, gut ischemia, everything will be. So unless you have adequate fluid in the central compartment and the peripheral compartment, there is no use of using the noradrenaline. So in the hypotension, unresponsive to fluid resuscitation only, you have to start the noradrenaline. And cardiogenic shock and respond to the other inotropes, and also maintenance of adequate blood pressure in the presence of hypotension associated with the brainstem death. They have suspecting the brain death. We have autonomic dysfunction. The brain death, we have brainstem death. All the vasomotor centers, everything will be located in the brainstem. You have significant disturbances or the vasomotor center disturbance. In that situations, for the maintenance, still you will get for the brain death donor, like end organ donation. You can maintain for some amount of circulation to preserve the organs like liver, kidney, and heart. So in that situations also you can use the noradrenaline. Is the hypotensive agent of choice in the maintenance of SH, subarachnoid hemorrhage, like a target BP is like a triple H therapy, have hypertension, hydration. In that situations also you can use the noradrenaline. And contraindications is severe hypovolemia and patient taking monoamine oxidase inhibitors. So what are the patients like monoamine oxidase inhibitors, like MAO inhibitors, particularly when the patients have antipsychotic medications and also patients have tricyclic antidepressants? What will happen if you use the monoamine oxidase inhibitors is basically they will break the monoamine oxidase, they will break the serotonin metabolism. If there is no serotonin metabolism, there is increase in the chance of catecholamines at the peripheral side and the systemic and the tissue level. So there will be increased surge of the noradrenaline at the tissue level and have rebound hypertension. That is the reason the patient having taken the monoamine oxidase or within the 14 days of treatment, you are not supposed to do noradrenaline. And it can cause mesenteric and peripheral vascular. Suppose the patient has severe mesenteric ischemia, gut ischemia, thrombosis. It will further aggravate the problem with and that's why it is not supposed to be. And severe peripheral vascular disease also. And weaning, you should not supposed to wean immediately. You can't stop the drug. You have to wean gradually. You can, if you are using the infusion doses, if there is a 10 ml, you can slowly come to 8 ml, 6 ml, 7 ml, 5 ml like that. You are not supposed to taper the dose as a sudden withdrawal. And adverse effects and complications is maybe you have tachycardia and arrhythmias, you can have hypertension crisis and exacerbation of MI. Suppose there is a silent MI of the patient. If you use noradrenaline, it can have coronary vasospasm, may occur, it can increase the ischemia MI. And also tissue necrosis if the exacerbation occurs, and reduced blood flow to the less vital tissue, especially in the skin and gut. And renal vasoconstriction may decrease the renal blood flow. And just I want to mention, noradrenaline ampoule is available as a 2 ml ampoule. Each ml is contains 2 milligrams. That is noradrenaline tartrate. That is equal to the base of 1 milligram of noradrenaline. Generally, in noradrenaline ampoule, you have 4 milligrams of noradrenaline tartrate. That is equal to the 2 mg of actual noradrenaline base. Now coming to the atropine. Atropine is an anticholinergic drug. The mechanism of action is blocks the action of acetylcholine at the parasympathetic rhythm, acts at the muscarinic receptors in the smooth muscles, secretory glands, and central nervous system. So first and foremost remembrance is, now in the cardiac arrest, there is no role of atropine. Be remember all the delegates, in the cardiac arrest situations, there is no role of atropine. Atropine is indicated only in symptomatic bradycardia only. In the symptomatic bradycardia, that too, if it is not useful in the second or third degree heart blocks, it is useful in the symptomatic bradycardia only. This is the atropine, the drug of choice for the bradycardia only. It's not the drug of choice for the cardiac arrest. It blocks the action of acetylcholine at the parasympathetic sites in the smooth muscles, secretory glands, and the central nervous system. It can increase the heart rate and also it can increase the cardiac output. Usually, atropine ampules comes as a 1 ml ampoule is 0.6 milligrams. You can increase the dose you can repeat the dose every 3 to 5 minutes for the symptomatic bradycardia, and maximum dose is up to 3 mg for the 5 doses you can use. And usually 2 to 3 mg is the full vagal dose is most patients. And one more thing I want to mention is atropine, if you give underdose, if you are not giving the full vagal dose, if you are just in a single dose, some patients may have bradycardia instead of tachycardia. That can be worrying for you. Why it is not increasing the heart rate, instead of increasing, it is going down because of the central action of the atropine on the anticholinergic action. The central anticholinergic is more of vagomimetic. In that situation, in the initial doses, you maybe have some vago on the bradycardia. In successive doses, you may get the tachycardia rhythm. It is the indications is the first drug for symptomatic sinus bradycardia. It can be maybe beneficial for the AV nodal blocks. And the drug of choice for the organophosphorus, you can use the large doses, and also may not be indicated. Already mentioned, pulseless self-collect and resistol is not the drug of choice. And precautions, MI and hypoxia. Basically, it increases the heart rate, so it can precipitate the MI and increase the myocardial oxygen demand. It is not effective, already told, in the second and third degree heart blocks. And doses less than 0.6 mg can paradoxically slow down the heart rate, as earlier mentioned, because of the central action of the atropine in the receptors at the central brainstem, and due to the increase the vagal speed, increase in the vagal. Now coming to the other drug is the imidazole. Is the anti-arrhythmic drug. This is called class 3 anti-arrhythmic drug. This is the phase 3 of the action potential of the cardiac action potential. It acts on that. It prolongs the cardiac action potential and the refractory period of atrial, nodal, and ventricular tissues. It has effects on the sodium, potassium, and calcium channels, as well as acts on the alpha and beta adrenergic block properties. Imidazole increases the coronary blood flow. It can decrease the cardiac oxygen requirements and suppress the ectopic pacemakers. Basically, this is the drug of choice for anti-arrhythmias. Generally, long-standing atrial fibrillations is our drug of choice because it is one thing is basically decrease the heart rate, means it increase the myocardial oxygen consumption because diastolic time is increased. And it can increase so that oxygen requirement, decrease the oxygen requirement, increase the myocardial blood flow, and use it to treat the severe tachyarrhythmias. Is the drug of the choice for the severe tachyarrhythmias. Generally, imidazole is available as a 3 cc ampoules. You can get 150 mg per ampoule. Each ml is 50 mg. You can use ampoules comes as a 150 milligrams. Basically, the drug of choice for the ventricular fibrillation, ventricular tachycardia. If the patient is no pulse, in spite of that, if the patient is no pulse, first choice is always CPR, second choice is defibrillation and adrenaline. If not responding, then you have to give the imidazole. Always make sure that CPR, shock is must, and epinephrine. Then only you have to give the imidazole if you are seeing the VF or VT on the monitor. So generally, you can use the 300 milligrams. That means 2 ampoules of imidazole given as a bolus dose, either IV or intraosseous in 30 ml NS. Can follow one dose of 150 mg after 3 to 5 minutes if needed. In the life-threatening arrhythmias, you can use 150 mg over 10 minutes. Repeat as indicated. The maximum dose is 2.2 grams in 24 hours. It can be used as infusions. Just I want to mention about the immelderon. Immelderon ideally should be diluted in dextrose only. Ideally, for infusions, generally infusions will keep immelderon in a dextrose only. Maybe in the emergency situations, we may mix with the saline, but ideally in the ICU setups, in the infusions for the chronic AF patients, generally we mix it in the dextrose only. The maximum dose is 2.2 grams in 24 hours. Indications for life-threatening arrhythmias, VF, pulseless VT, unresponsive to shock, and CPR and vasopressors, and recurrent hemodynamically unstable VT also you can use this. What are the adverse effects? So if the patient had a significant, once you give very fast, you may have significant bradycardia, you may have heart blocks. And also you can have hypotension and excessive prolongation of the QT intervals. Normal QT interval around 0.4 seconds. If it is more than 0.4 to 0.45, if it is more than 0.6 seconds, that means there's a significant prolongation of QT intervals, and it can be potentially the effects of warfarins, calcium channel blockers, and also beta blockers. The long-term administration may cause photosensitivity, hypothyroidism, lung fibrosis, and pleural fibrosis, and prolonged PT and corneal deposits. These are the side effects of the immelderon. Now coming to the lignocaine. Just I want to mention, most of the atrial arrhythmias will be managed by the immelderon, and most of the ventricular arrhythmias, the best drug may be lignocaine. And basically, lignocaine is alternate to immelderon, particularly for the ventricular fibrillation and pulseless VT. The dose is 1 to 1.5 mg per kg IV or intraosseous. It can be used as infusion 1 to 4 milligrams per minute. Just I want to mention for the students' purposes, lignocaine freely available in the almost in the hospital scenarios. The basic thing is you have to know which type of lignocaine, whether it is a preservative free or preservative. Most commonly used lignocaine in our hospital settings is for the giving local infiltration. For the local infiltration, that is having the preservative. And that is 2% lignocaine preservative like a methylparaben. It is not supposed to give as a IV dose in case of any cardiac arrest or any other scenarios. Make sure that some of the commercial preparations like Zylopard, they are preservative free. Make sure that if it is a preservative free only, you are supposed to give for the ventricular arrhythmias. If it is a regular lignocaine for the local infiltration with a preservative like methylparaben, you are not supposed to use it. And second thing is, when you are in a hurry, you can have to give the drug very fast. You have to see. Some of the surgeons will use lignocaine with adrenal preparations also available. 2% lignocaine with adrenal, and that is also useless. So better is preservative-free lignocaine. Like a preparations like Zylopard is available, then that is the best drug for the usage. And also generally available lignocaine is 2%. That means each milligrams is 20 milligrams. So 1 to 1.5 mg as a 50 kg person, that means 50 milligrams or 75 milligrams. That means you can safely give around 4 to 5 ml, around 3 to 4 ml direct IV preservative-free lignocaine. And coming to the adenosine, this is the anti-arrhythmic action is mainly used for the supraventricular tachycardias. Basically, when most of the supraventricular tachycardias, adenosine is the drug of choice. The slow impulses from the formation of the sinoatrial node, already arrhythmias discussed yesterday, and slow conduction time through the AV nodes can interrupt the re-entry pathway through the atrioventricular node. So basically what is happening is from the SC node to AV node, there is a atrioventricular pathway there. So it will interrupt the re-entry pathways, any conduction re-entry pathways through the AV node. It can block that issue. And also it is used as a coronary vasodilator also. The onset of time is immediate and peak will be 10 seconds and duration is 10 to 30 seconds because it is very, very fast acting drug. The moment you give the drug, it is unless it reaches the drug within 20 seconds or 20 seconds, there is no use of this drug. So best drug is, so how to administer the drug? This is available as a 2 ml ampoules. Each milligram, 1 ml ampoules is a 6 milligrams. If it is a 2 ampoules, it is a 12 milligrams. The 2 will be administered as a rapid bolus, like 2 seconds, followed with a rapid flush of 20 ml saline. Ideally, what you have to use is, if you have central line, better use it. If it is not having the central line, take the anticubital vein and with the cannula, you can use the three-way cannula, three-way connector. And one side you can use the adenosine with diluted adenosine, and second time you can use the 20 ml flush. Have two pre-filled syringes attached in a two-way cannula. Rapidly, you can give adenosine like a flush and raise the hand. So dosage is adenosine 6 mg rapid peripheral IV bolus or 3 mg if you have central venous access. If it is not responding to the first dose, you can use the not tolerated. After 2 minutes, you can give the adenosine 12 mg rapid flush followed or 6 mg in the central venous access. So indications is rapid conversion of the normal sinus rhythm to paroxysmal PSVT, supraventricular tachycardias, including those associated with the axillary pathway like Wolff-Parkinson White syndrome. It does not convert the atrial flutter, atrial fibrillation, or VT. So be remember that atrial flutter, atrial fibrillation, VT, it is not the drug of choice. It is mainly for the supraventricular SVTs only. If you have atrial flutter, atrial fibrillation, you can use amiodarone. If you have VT, you can use amiodarone or lignocaine. So it is as an aid to differential diagnosis of narrow or broad complex. If you are in a dilemma, whether it's a narrow or broad complex, you can give adenosine. It will slowly decrease the rate. Then you can analyze the rhythm, whether it's a narrow or broad complex tachycardia. Slowing the AV conduction within much makes the atrial activity more visible on the ECGs. So what are the contraindications? Generally hypersensitive to adenosine and second and third degree heart blocks, because further aggravate the block, and SNO dysfunction such as sick sinus syndrome and symptomatic bradycardia. They have anaphylactic reactions. Adenosine may have bronchospasms and also like asthmatic patients, and may you have severe hypotension. Sometimes you may have flushing, like side effects like a flushing is there, and resolve rapidly on the treatment due to the drug start duration. And explain the possible. Basically, you have hot flushes, burning chest like that, burning pain abdomen like this. So very small symptoms. Explain possible adverse effects to the patient before administration. Ensure the patient understands that these side effects will be short-lived. So like flushing, dyspnea, chest pain, there's a common side effect like dizziness, apprehension, and infrequent maybe you have transient arrhythmias and recurrent SVTs, hypotension, tingling in the arms and legs, and they have metallic taste. Rare is bronchospasm, injection site reactions. This is about the adenosine. Adenosine is a drug given as a bolus only. Generally, we won't keep it as an infusions. Now coming to the magnesium sulfate. This is a physiological calcium channel blocker. Indications in cardiac arrest with torsido dependence, because torsido dependence already explained like a polymorphic VT with the varying this QRS complexes morphology, and also in diastolic toxicity, and patient with hypomagnesemia states that may lead to the arrhythmias, and also prevention and treatment of seizures in case of severe preeclampsia and eclampsia. And sometimes in case of severe hypokalemia also, along with the potassium, you can use magnesium also. The dosage for the torsido dependence in cardiac arrest is 1 to 2 grams. Usually magnesium is available as a 2 ml ampoules. Each ml contains 500 mg. That means 1 ampoule contains 1 gram of magnesium. You can use 1 to 2 grams. That means 2 ampoules of magnesium divided in 10 ml and 5% dextrose and normal saline. It can be used as an IV or intravenous for 5 to 20 minutes. And torsidis with pulse or acute MA hypomagnesemia also can be used as a dose as 1 to 2 grams in 50 to 100 ml dextrose over 5 to 60 minutes IV or intravenous. Then 0.5 grams to 1 gram per hour. In this situation, for a severe hypomagnesemia, you can use as infusions. Whereas in cardiac arrest in torsidus or VT, you can use as a bolus dose. Both, either way, you can use the magnesium. And side effects are flushing, sweating, and mild decrease in the heart rate and BP. Among the side effects, most commonly used by the gynecologists for the eclampsia cases, where you have to monitor for the knee jerk and other muscle weakness, other things. Now coming to the last drug in this talk is dopamine. Dopamine, when it is used, actually it has no indication for the emergency cardiac arrest. Whenever the patient got RVSC, retinal spontaneous circulation, if you have patient head pulse and BP is around 70, then you can start the inotropic infusions like dopamine or norepinephrine. So dopamine generally is the first line, indications as hypotension and after RVSC and symptomatic bradycardia. The bradycardia, you can give 3 milligrams maximum dose. It's not heart rate is not. You can start the dopamine infusions also. It is dopamine you can use as a 2 to 20 micrograms per kg per minute. Generally, dopamine is available as a 5 ml ampoules, that is 200 milligrams ampoules. So you can use 2 to 220 micrograms. You have to calculate according to the body weight, micrograms kg per minute, and titrate as per the requirements. Always Any infusions you are not supposed to stop immediately. Any infusions you have to taper very slowly, either norepinephrine or dopamine. And take home message or important points is drugs for the bolus is adrenal, always no doubt, is the bolus emergency drug for cardiac arrest, imodurine for the ventricular arrhythmias, and all type of arrhythmias. And atropine is the drug of choice as a bolus for the bradycardia, maximum of 3 milligrams. Adenosine is the drug of choice for the supraventricular tachycardia. You can use up to 6 and 12 milligrams. Lignocaine you can use at the 1 to 1.5 mg per kg for the ventricular tachycardias. And magnesium sulfate you can use 1 gram to 2 grams as a bolus doses. Coming to the infusions, once RVC comes, retinal spontaneous circulation, the BP is low, you can use adrenal infusions around 0.03 to 0.5 mg. And also you can use imodurine infusions. Imodurine infusions generally preferred like 6 samples of imodurine, like each ml 150, maybe you can have 900 milligrams in 50 ml dextrose. You can titrate depending on the calculations. Atropine generally infusions used for the organophosphorus poisoning, not for other situations as per my knowledge. And adenosine generally not preferred for infusions, mainly for the SVTs. Lignocaine infusions for the recurrent VTs, you can use the lignocaine infusions. Patient have recurrent VTs, and magnesium sulfate can be used as infusions, and also dopamine infusions. Whenever you have got dopamine, when RVC comes, you can use the infusions. In cardiac arrest situations, make sure that bolus, saline flush, and limb rise, and pulse is present. Always use infusions. If there is no pulse, bolus. If the pulse is there, infusions. Thank you. Thank you for over, sir. Thank you, sir.
Dr. Satish, very precisely you described the role of these emergency medications in cardiac arrest and pre-arrest conditions. Very nicely done. Any questions from the house? You can write in the chat box.
Sir, can I make a small comment?
Yes, yes.
Actually, adrenaline infusion